Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual, and today some more important clinical care tips, almost on rule number 200. Rule number 197. Take responsibility for all and any of the errors that take place while you're in the ER. So some rules, as you've seen before, are just easier to explain with an example. When I was a resident, in fact, when I was an intern, I remember coming one morning and rounding on some patient. One of them was a newborn who had a rule-out sepsis and had to be admitted for antibiotics until blood culture, urine culture, and CSF culture were negative. Kind of a usual story. Shortly after doing my pre-rounding as a senior, just talking to the nurse, talking to the mom, it became clear that the patient was placed on IV fluids. Patient was about 4 kilograms, so it should have been about 16 milliliters per hour, given the 4-to-1 rule for maintenance IV fluids for a baby. But somehow something went wrong, and instead of 16 ml per hour, the patient, for some reason, got 160 ml per hour. Somehow another zero was added by the nurse. And clearly that's a very big mistake and a very big difference. Nonetheless, the patient was fine because maintenance IV fluids are safe, and the patient was also during the night eating and breastfeeding fine. But it wasn't until the morning when we noticed the mistake. Now, needless to say, the morning team that was there had nothing to do with it. The patient was seen last night, was placed on IV fluids by the resident. There was an different attending that supervised that resident last night. Really, none of us morning team had anything to do with this. Nonetheless, I remember very distinctively that my attending, who was the morning attending, immediately grabbed me, went to the room, discussed exactly what happened with the mom, and apologized for the mistake. And I remember listening to the conversation and hearing him apologizing for the mistake as if he is responsible for that mistake, when the truth of the matter was that he wasn't even there. He wasn't part of the decision. It was the nurse's mistake, etc. But he was the attending, and he was the leader of the team, and he was the leader of the team that morning. And I was very impressed by him, how he took the full responsibility, apologized to the mom, and disclosed everything that happened. I can also tell you, I also remember very well how the mother was very appreciative that he came forth and exactly gave her an update of what happened. And to me, that was a great example of leadership-like behavior. Again, he as the attending had nothing to do with it. However, he took the responsibility, 100% of it, and apologized to the mom. Here's another example for that rule that I got from a colleague of mine. One of my colleagues, who was also the attending at the time during a shift, remember having a 7-year-old who came in with some kind of infection and had to get IM ceftriaxone, but for some reason got 10 times the dose. My colleague, who was the attending, immediately took charge and apologized for the mistake when this happened. Again, he wasn't the attending who put the order, it was a trainee. Nonetheless, as the attending, you're supervising the trainee, and he took it as his own fault. Number one, he went to the parents and disclosed what happened. Number two, he called the pharmacist and tried to understand exactly how it happened and spoke to the nurse who administered that mistake in order to understand exactly where the fallout was. But as the attending, although he did not exactly put the order, as the attending, he is the leader. He investigated the mistake, apologized for the parents, and made sure the whole team was involved all the way to the pharmacist. This is what a good leader does. Take responsibility for anything and everything that happens during your shift or during your watch. Rule number 198. If you can fix it, you should check for it. So again, this rule is one of those rules that is just best to explain with an example. So let's say I work in the pediatric emergency department and there's a child or an adolescent who comes in with altered mental status. So altered mental status is something that has a very wide differential and many things can cause it. When that happens, however, this rule comes into play. And it comes into play early. So in my opinion, anything you can and should fix, you should check for first. For example, in the setting of altered mental status, the child really should have his or her glucose checked, as well as sodium. Hypoglycemia, hyponatremia, and hypernatremia all can cause altered mental status. And those should be checked ASAP. All of those can cause altered mental status and you can fix them. Anything you can fix, you should check out first. Check the glucose first because you can fix it. Yes, you can fix meningitis as well. Absolutely, the patient should have an LP. But giving antibiotics, which would be the first step if the patient indeed has meningitis, doesn't exactly fix the problem. It's a necessary step and should happen as soon as possible. However, it makes no sense to wait for an LP or LP results or even just doing the procedure without making sure that the glucose and the sodium are normal first. So check the glucose, check the sodium, because you can fix those before you go ahead and do LP to check for meningitis or CT head to check for tumor or bleed, which are very appropriate when seeing a patient with altered mental status. But if you can fix it, you should check for it. Another thing that comes to mind in a child with altered mental status is the tox screen. And don't get me wrong, the tox screen is a necessary step in the workup of a child with altered mental status, but it's not something that usually we can and need to fix. If the child smoked something, for example, there's no reversal agent for that, and if he or she are stable, there's not a whole lot you can do. So, yes, I'm not against the tox screen, but it's something that can wait. It's not something I need to check now because it's not something I can fix now, whereas the glucose and the sodium are significantly more urgent. Now, one of the other ways this rule comes into play is from a different perspective. As a physician, as a clinician, you can check for a lot of things. All you have to do is type a few words on the computer, place an order, and the patient gets whatever test you wish. However, many times the test that you check or apply to the patient really doesn't have any consequences and does not change the course of the treatment. I would argue in that scenario, maybe that test is not necessary. A good example that I always give to my trainees is the respiratory viral panel, a notorious test that rarely changes the management and rarely you can do anything about, somewhat painful, certainly a little expensive, and it's most of the time unnecessary. So anything you can fix, you should check for it and check for it now. Something like a virus, maybe you can check, but you can't really fix, don't need to fix, so maybe it's not a good test. So keep in mind rule number 198. If you can fix it, check for it. Rule number 199. When starting antibiotics on an admitted patient, always think about discharge. So this rule, I gotta say, as a pediatric EM doctor and someone who works only in the emergency department, is a little hard to apply and a little hard to keep in mind. But try to keep that in mind because it's very important for the sake of the well-being of the patient. Again, as before, good to start with an example. Let's say I admit a patient with an abscess. I do my little procedure, I drain the abscess, irrigate, give antibiotics, etc. But let's say the patient is febrile, possibly bacteremic, I'm getting a blood culture, and I'd like to admit the child for IV antibiotics. Sure, I can give vancomycin, and vancomycin will probably be the right choice for a person with an abscess. I can give it IV, no problem. However, I have to keep in mind what is the hospital is going to do in a day or two or three when hopefully the patient gets a lot better. So if the patient improves and there's no more fever, that patient cannot go home on IV vancomycin. At least that's not ideal. Can the patient get Clinda? Can the patient get Bactrim? So as a physician, I have the responsibility to either start a drug that the patient can continue on while he or she going home. For example, clindamycin can be given IV on the day of admission in the hospital and can be given by mouth upon discharge, or maybe Bactrim. However, if I start the patient on IV vancomycin and I fail to take culture so we can get the specific species that causes the problem, that will put the hospitalist in a very difficult position. What antibiotics would that patient get upon discharge? Oral vancomycin is not exactly an option. Bactrim or Clinda may not cover that specific Staph aureus or MRSA that is causing the problem. So at the very least, as a physician, I have the responsibility to either get a culture so we know definitively what species is causing the problem and give the appropriate antibiotics, or at the very least, think about discharge. Think about whatever medication I can give now, can't it be given by mouth upon discharge? Remember, if you're giving ampicillin to a child with pneumonia, which you should, you can always send them on amoxicillin. If you're giving ceftriaxone, you can always send them home on a third generation cephalosporin. So think about what antibiotics you're initiating now and what can you do upon discharge, even though the patient is not going home anytime soon. And that is it for today, guys. Thank you very much for listening to PEM Rules. Let's briefly review what we learned. Rule number 197: take responsibility for all and any of the errors that take place in the ER. You, as an attending, are responsible for everything, good or bad. Take the responsibility, do what's necessary to prevent those errors again, disclose issues to the parents, to your nurses, etc. Rule number 198: if you can fix it, check for it. Many times you can do a lot of testing in the ER, but many of those tests really don't have any clinical significance. It's not something you can and need to fix. Check for what you can fix now. Glucose and sodium always come into play or come into mind when you're talking about a child with altered mental status. You can check for them and you should check for them because you can fix them. You can't fix the drug screen, you can't fix right now any head bleed, etc. Check for those later. Rule number 199: when starting antibiotic on an admitting patient, think about discharge. Can you give these antibiotics by mouth when the patient is getting better and go home? At the very least, get a culture to help with that decision. But if you're not getting a culture, think about, can this patient be discharged on these antibiotics I'm giving him or her on oral treatment? And that is it for today, guys. Thank you very much for listening to PEM Rules. Please continue to write back. Check out the Facebook page, which now has a lot more educational material and some announcements. Same for the website. And again, as always, if there's any topic or interesting patient that is PEM related and you want to discuss on the show, please contact me through the website and I would love to have you as a guest. Thanks again, and I hope you enjoyed this outro. This is Wood by Alice in Chains, one of the best bands from the 90s. Hope you like it. Have a great day.